Hi everyone, my name is Sam Botros and I'm the president and founder of the St George's University of London Cardiothoracic Surgery Society. Today I'm going to be doing an exclusive interview with Dr. Gopal Bhatnagar. Why did you choose to go into cardiac surgery?
Yeah. Complex question, I guess. So I trained to be a general surgeon first. I did 5 years of general surgery and found it, certainly I went to medical school because my role model was my an older grand uncle who was the only surgeon in the family, and found that really wanted to pursue that. And so I went to medical school wanting to do surgery. We did general surgery, did it for 5 years, found it exceptionally challenging. But to be honest with you, I did cardiac surgery because there was really no error no error possible. The latitude for error is minuscule. The complexity of the operations. I love the physiology of the cardiovascular system, and this kind of married my desire to perform my technical skills in a high stakes, one of environment. So I like the stress of cardiac surgery. It had to go. It's a beautiful symphony when it goes well, and it's technically very, very challenging. So I did it as a somewhat started as a personal challenge to myself to perform what at that time, going back 40 years ago, was really a very new and evolving field, very dynamic, evolving field, and so it was a technical challenge to me. Yeah.
And what would you say is the most memorable case you've encountered so
Yeah,
far?
well, yeah, I thought about that question that you put in. For the most part, I do not remember much in the way of my successes. My most memorable cases are my failures. 42-year-old woman, 2021, very straightforward aortic valve replacement that I did. Can never really figure out why she had a catastrophic collapse in the ICU. Thereafter, some sort of coronary artery obstruction. Could not salvage her, despite trying to initiate a wide variety of mechanical circulatory support mechanisms. Uh, so you remember that those are those are what that I remember, despite the 20 plus years that would pass. Fortunately, there are. It's my most memorable successful case would be a young woman actually who had just delivered about 3 days prior. She suffered a cardiac arrest from amniotic fluid embolus. Most likely it was a diagnosis. I happened to be just sitting in the ICU looking at x-rays when some of the staff members came and kind of were talking about this and asked me to place an intra-aortic balloon pump. I went over to see her. She's in full cardiac arrest. Intra-aortic balloon pump is a rudimentary technology, not be sufficient. I said, we really don't have any other technology available to us at that time except full cardiopulmonary bypass. So we actually took the chance after 50 minutes of CPR. The survival is going to be negligible. But she was 33 years old and just delivered a baby, so the emotions were very high. So I felt we'd give her like even was an unreasonable chance. And so we actually took her to the operating room through full sternotomy at that time, placed her on cardiopulmonary bypass, hypothermic arrest, cooled her down to about 18 degrees, rested her, actually got her heart started back up again. And then I kept her under hypothermic arrest to slowly, although we warmed her up. About 3 days later, we were able to wean her off the cardiopulmonary bypass machine, what we call. At that time, it was before devices such as ECMO were around, and she actually woke up. So of all the things, I imagine she woke up neurologically intact. A few other minor complications we had, but really nothing. So in terms of all the things that were ever stand out of the thousands of cases that I've done, it was actually one of the most simplest technical procedures, placing a patient on cardiopulmonary bypass we do sort of day in, day out. But that always will stick out in my mind as a very rare, maybe once in a lifetime, but it's really, really great to see that outcome. Yeah.
What would you say in the last few years has been the most significant advancement in cardiac surgery in your
Yeah.
opinion?
Well, the most significant advancements in the last few years have been really around cardiology, structural cardiology, such as TAVR, where we can place aortic valves just transfemorally. There's no doubt that that's a complete paradigm changer in the care of valvular patients and the advancement of percutaneous technologies. If you were to say in the field of cardiac surgery, I would say it would be the advent of now long durable mechanical assist devices. Sort of the artificial heart is now within grasp. Transplant, of course, has been around for decades. In fact, the first transplant was done before the first coronary bypass was done. But mechanical or circulatory assist device like an LVAD implant, RVAD implant, and a total artificial heart has really been elusive for a wide variety of reasons. But now with the technology catching up to us, I would say the greatest advances in the last within the last 5 years, 5 to 8 years, have been the advances in mechanical circulatory assist.
What do you see in the future of cardiac surgery?
I see.
For the future?
Yeah, well, cardiac surgery is an interesting profession. I mean, we didn't really exist in its modern form until 1968. And so the 70s, 80s, 90s saw this rapid evolution. And then, of course, cardiovascular disease being the number one cause of morbidity and mortality around the world has attracted a lot of attention. Cardiologists have been very instrumental in advancing in the care of cardiac diseases, percutaneous angioplasty, stenting, now structural heart disease. So cardiac surgery's had its ups and downs there in terms of, are we still going to stay relevant in the long term? Of course, my belief is that we will stay relevant in the long term. I would see that minimally invasive procedures, robotic, the use of, I mean, everybody's talking about AI. We'll see where it goes, but I certainly think that it's going to evolve very rapidly in our decision making and ultimately into our diagnostics. Many surgeons think that we're irreplaceable. However, if you take a look at robotic technology now, imagine if I do one operation, a rare operation, and I do that maybe 5 times a year, how good am I going to be at that? However, you could program an AI assistant or even a physical surgical robot that would have the entire compendium of surgical knowledge at its disposal at any given point in time, including 3D mapping, imaging, radiological techniques. I mean, every imaging is stored in its AI consciousness, and it could theoretically reproduce the best of the best surgeon's operation repetitively, no matter where it was in the world, whether it did it once a year or whether it did once a 10 years, or if it did it once a day, it would give you that repetitive, perfect technical result. So I think that those are sorts of very, very exciting things that will happen over the future. In the immediate realistic future, things are going to progressively move towards a minimally invasive and then percutaneous techniques. So I think the profession will evolve from, there has been a dichotomy between interventional cardiology and surgeons. We came up through general surgery and we were surgeons. Cardiologists came up through medicine and became cardiologists and then trained in intervention. I would see ideally some sort of commonality of training so that practitioners in the future would be cardiovascular interventionalists. Some may be more geared towards, the ability to do open surgery, because that may still be necessary. But there'd be a lot of cross-pollination in skills in terms of wire techniques and percutaneous techniques and knowledge.
You mentioned a lot about robotic surgery being potentially in the future. I understand currently you do robotic cardiac surgery at Cleveland. For things like mitral valve repair, tricuspid valve repair, atrial septal defect, and even CABG. Can you talk to us a little about the advantages of using robotic techniques and also a little bit about the challenges and disadvantages?
The advantages are somewhat self-evident. If you take a look at a minute smaller incision, it's a faster recovery for patients. You don't have to do a full sternotomy. So in properly selected patients, the ability to perform a robotic mitral valve repair, closure of an ASD leads to a much faster recovery. There's less blood loss, less other complications associated with that, especially on the wound side. But you have to be good at it. You have to be good at mitral valve repair before you can do it in a robotic session. So this becomes, most people get their skill in mitral valve repair from open cases. Now, with fellowship programs that are good training programs, I mean, our main campus in CCF, Ohio, is a world leader with Dr. Mark Roselli there in mitral in mitral and aortic surgery. So we have Dr. Mark Gillenov is on the robotic mitral side. Dr. Roselli is on the aortic side, just to make that clear. But they have done 1,000 plus robotic mitral valve repairs with no mortality, which is amazing, right? So those are a lot of the benefits associated with coronary bypass surgery. Is become technically is more difficult because it is a smaller scale surgery where a coronary artery is only about 2 millimeters in diameter. So having to stitch that is still the connection is still very time consuming when it's done robotically. There are surgeons that specialize in it, do it exceptionally well, but right now less than 5% of coronary bypass surgery around the world is done robotically. And the main thing is going to be around the connector technology. Past connector technologies have resulted in too much restenosis, but eventually I would see the fact that if we have something beyond a sewn anastomosis with Prolene and some sort of connector technology that's, whether it's a bio glue, whether it's something else, then you could see robotic coronary, I think, would take off. There are some other constraints around robotic surgery. It's expensive. A robot is an expensive piece of technology. There's a great deal of disposable. So the cost of robotics in many parts of the world makes it prohibitive. Now, in jurisdictions like India, Turkey, Eastern Europe, not saying that North America and Europe are not sensitive to cost. In fact, more and more so, every jurisdiction is being. But we're seeing a lot of innovation coming from parts of the world that had not led in the innovation of medicine. Now are leaping forward, and we're seeing great technologies coming out of India and China as well. So, and they're very, very value based markets.
And Dr. Bhatnagar, what would you say is your favorite cardiac surgery?
My favorite cardiac surgery? My favorite cardiac surgery is something called a Bentall procedure, where it's a complete replacement of the aortic valve, aortic root, with a wide variety of composite grafts. Whether you do it as a pulmonary autograft, so-called Ross procedure, whether you do it as a mechanical, simple mechanical valve conduit, or whether you do it as a biobental. So I love working in that aortic root and the aorta.
Okay, one of in fact, the first cardiac procedure I ever saw was a David procedure.
Oh, David, yeah, that's named after my professor of surgery, Dr. Tyrone David, of course, at the University of Toronto. So most people perform the David. I've seen many David procedures performed by the master himself.
Wow,
yeah,
that's amazing.
Yeah. So now it's part of the generic valve sparing root replacements that we do, and I think it's a brilliant operation. We do it quite regularly here at Cleveland. And actually, Dr. Yaqub Magdi has a variation of that procedure as well, the valve sparing. There's both different indications. Of course, Dr. Magdi is a legend in cardiac surgery, of course, as you well know, coming from the UK, and he just continues to establish and do great work in his home country of Egypt.
Doctor, what would you say are the most important qualities and skills you need to be equipped for a career in cardiac surgery?
Yeah, well, I think you have to care. There's nothing magical about, sort of saying, I need to have this to be a good surgeon. I think you have to care. You have to be passionate about it. Now, this may seem like overarching statements, but not everybody, and let's be realistic, not everybody goes into medicine with a burning passion that medicine is their number one, thing in life. And that's just realistic. We all do our cardiac surgery will consume an enormous amount of your mental and physical energy in terms of and time during the day. You can be when we get an aortic dissection called at 2:00 in the morning, that the next 8 hours of your life is going to be occupied potentially in the operating room, and many hours after that with either bleeding or taking care of that patient. You have to be prepared for that. But you have to care for the patient, and I think that makes a good physician. And I think caring about the outcome of the patient is paramount when you are a surgeon. You are inflicting a controlled level of violence to another human being. They trust you that you are going to do your absolute very best to get them through, and that's a great burden. A privilege as well as a burden that's not to be used. On the pragmatic side, yeah, you have to like to work. Your life will never be, when people talk about work-life balance, work will always be the predominant thing in your life.
Mm-hmm.
But if you love it, then that'll be your work-life balance. You do need a significant amount of physical stamina to stand. I mean, a simple operation is going to take you 4 hours.
Mm-hmm.
Yes, there's robotic technology, but I mean, a robot, just so you need the concentration ability to do it. And there's other ways to facilitate it, but you need the physical stamina as well to do it. So maybe that doesn't completely answer your questions, but you have to care and be passionate. So let's leave it at those are the two things that I think are most important.
Dr. Bhatnagar, you are a professional with over 30 years of experience in cardiac surgery. What advice would you give to a medical student who's interested in pursuing cardiac surgery as their career choice?
I mean, if you love it, then pursue it. Don't let anybody dissuade you from it. It's going to be a long road. It's going to be a difficult road. Ups and downs. Be honest with yourself about whether you really have what it takes to become, a surgeon and a cardiac surgeon to do that. But if you're going to commit to it, then just commit to it. And commit to great training. Find programs that can train you very well, because your time in your residency and in your fellowship are where you will learn all the things that you're not supposed to do. I joke with residents that a residence and your training program, I can train somebody to do cardiac surgery probably in about 18 months. Okay. Why do you need 10 years? The other 8.5 years is spent how to correct mistakes, how to get yourself out of trouble. And so the breadth of your training is going to be very important. But if you love it, don't worry about work-life balance. Don't worry about how much I'm going to get paid, how much there's too many negatives if you start boiling it down. If you love it, just commit yourself to it.
Thank you so much.
You're very welcome. It's been a pleasure.
Thank you very much.
You're very welcome. My pleasure.